Hello, it's nice to be with you for this presentation. I was asked by your instructor if I would be willing to talk to you about managing in a disaster and specifically special considerations for children. She was kind enough to share with me the chapter you are reading in your textbook on principles of disaster management and clinical practice. It's always interesting to read these chapters and realize how much information can be packed into one chapter. And I know, of course, as nurse practitioners, they're hoping that you remember all of this. I will tell you that some of the most important parts of what I think they provided to you was in the very first table in 39.1 because it told you about the vulnerabilities of children, and it specifically talked about the physiologic and anatomic differences of children. And this is important because many people, as much as we have preached it, still treat children like little adults during a disaster. And that really cannot be. I am going to talk to you about some of the things that are covered in your book, but a lot of the things that aren't. I won't go into any detail about the treatment of specific diseases, and especially about the infectious diseases and things like ricin and anthrax that are clearly indications of terrorist attacks, because your book does a good job of outlining the treatment of those conditions for you. What I will say about this is that it's important to know what is normal. We should never forget that it was one astute physician that recognized anthrax, and thus we were able to treat other people as they came in with symptoms. I will also add that you have some information on smallpox. And smallpox at this point, unless you are working in a lab that works with smallpox, is always considered a terrorist attack. Your book does do a good job, so I will leave it at that, and I will move on to the presentation. Some of the objectives that I hope to get through with you are to identify the disaster life cycle, also known as the phases of a disaster, to define the incident command system, to identify some of the roles of registered nurses and nurse practitioners, nurse administrators, and in fact, any nurse involved in a disaster, and to describe some of the special considerations faced during a disaster. As nurses, you will be surprised, but you will be expected often to play a leadership role. When I was working for the Division of Immigration Health Services and attended a training on leaders developing leaders, one of the people that led that program was Mary Lou Anderson. And Mary Lou Anderson was a pharmacist by training, but a poet on the side. And she wrote this poem that said, leaders are called to stand between in that lonely place between the no longer and the not yet, and intentionally make decisions that will bind, forge, move, and create history. We are not called to be popular. We are not called to be safe. We are not called to follow. We are the ones called to take risk. We are the ones called to change attitudes, to risk displeasures. We are the ones called to gamble our lives for a better future. In many ways, that is what all nurses have been doing for over a year now during the COVID crisis. Let us begin by defining preparedness. And many times we define it through exclusion. It is a precipitous or gradual decline in the overall health status of a community with which it is unable to cope with adequately without outside assistance. This came from healthcare disaster management guidelines for the evaluation of research in the Epstein style. It is a brief writing, and I would suggest that you all get it. You can find it online and download it. We also need to think about our current levels of preparedness. And one of the ways is to look at the hospital settings. Many of you, as acute care pediatric nurse practitioners, might be working in a hospital setting. Hospitals in most states have a high degree of participation in coalitions. On average, 89% of hospitals were in a coalition, and 18 states had universal coalition participation. And what we know is that one of the top priority indicators of a state is health preparedness. And being involved in a coalition generally improves preparedness. Some of the indicators of preparedness are incident management and adoption of the Nurse Licensure Compact. We also know that it is really important to think about things like cross-sector communication, institutional quality, and and things that are more infrastructure, like water security and workforce resilience and infection control. And I don't know anybody that does more work related to infection control than nurses. And then we need to think about countermeasure utilization. So the percentage of people ages 6 months and older who've received things like the seasonal flu shot. And it is flu season, so it might be a good idea to consider getting your flu shot. The other two are patient safety, so the percentage of hospitals with a top quality ranking, and then health security surveillance, which is the public health laboratory has a plan for 6 to 8 week surge testing capacity. And I think we all realize that the testing we need to do changed drastically during the pandemic. And many people who were prepared had ended up not as prepared as they thought they would be for something like a pandemic. Just to cover the one or two of these indicators that I think are really important to us as nurses, and nurses at any level. The number one was an adoption of a nurse licensure compact. Now, this is referring to registered nurses. And at the time in 2008, when the report was written, there were 31 states that participated in nurse licensure compacts. But there are also efforts to have similar compacts for nurse practitioners. Obviously, that is a much bigger challenge. What then is a disaster? Your book did a wonderful job of talking about the difference between natural disasters and man-made disasters, and the difference between what we might consider an emergency and a crisis. Any natural or man-made event that causes more damage or casualties than the community is able to handle is considered a disaster. This can be a plane crash, anthrax attacks, train derailments, mass shootings, hurricanes, tornadoes, earthquakes, famines, and as we all know, pandemics. It could include mutually assured destruction, which is a nuclear attack. This is less likely than a nuclear event. In the U.S., we had 3 Mile Island, but that was nothing in comparison to things that happened previously, like Chernobyl, or the massive earthquake in Japan that then caused a nuclear meltdown. This is damage to St. John's Hospital, Tower 2, with ruins of a local theater where 2 people perished in the foreground. This is in Joplin, Missouri, and this was from a tornado. Most of you will remember when we had Zika and the cluster of effects on developing babies that we now know as congenital Zika Syndrome. And we see those in the small head size, microcephaly, the decreased brain tissue, and damage to the back and the eyes. They tended to have extreme muscle tone and limited range of motion, among other problems. This obviously was devastating for both mom and baby. You may also remember the Flint water crisis. And why do you care about this as pediatric nurse practitioners? Well, one of the reasons this is important is because anytime there's lead in the water, obviously it has a greater impact on pregnant women and their fetus and then young children because of the damage done by lead. We make preparations in advance. You need to make preparations in advance, and you never have trouble if you are prepared, according to Theodore Roosevelt. Of course, then we have to figure out what it means to be prepared. It's important to know the life cycle of the disaster, and I'm sure most of you have seen this. One of the things that many people do is they look at the disaster and think that's the beginning. But in reality, it isn't. This is cyclical, and you're better off if you begin with mitigation activities first. Things put in place to prevent damage or loss of life in the first place. From hurricanes, it might be that you put regulations in place so that people don't build in places that are likely to be highly damaged or are prone to storm surge from a hurricane. You do risk reduction, you do prevention, and then you do preparedness. And even if we do as much mitigation and as much risk reduction as we can through things like building codes, we're always going to have issues of disasters that do happen. And so it's important to be prepared. The actual response is the short part. It's usually a few days to a few weeks, and then we move into recovery. And that's the piece that can take months or even years, depending on the scope of the disaster. I always love giving a little bit of information about the history of disaster preparedness. In the United States, that begins with civil defense, and knowing that in 1803, the United States passed its first legislation in an attempt to prepare for emergencies. Most of the legislation that followed was in response to major disasters like the Portsmouth, New Hampshire fire of 1803. From 1803 until the Disaster Relief Act in 1950, there were 125 pieces of legislation related to disaster assistance. Until 1950, all of those responses were ad hoc, and it only became coordinated with the establishment of FEMA in 1979 and the passage of the Robert T. Stafford Disaster Relief and Emergency Assistance Act of 1988. That act has been updated many times, but you can still order copies or download copies of the entire act online, and I would suggest you do so. And when you have time, not while you're in school, but when you have time, you take the time to read it. One of the important things that happened is how often the roles and responsibilities in disaster assistance have changed. Over time, it's moved from the Office of the President to the Office of Science and Technology Policy and the Executive Office of the President to the General Services Administration to Housing and Development to parts of DOD to the Department of Commerce and then to FEMA in 1979. And then we had 9/11, and things morphed and changed and moved all over again and continue to hop all over the place back and forth. Anybody that's ever worked in a hospital where they are constantly, shifting the chairs around about who does what knows how confusing that can be. As soon as you learn one system, they've moved on rather than trying to perfect a system that exists. It is one of the problems that we face. The history of the incident command system actually began with massive wildfires, really in Nevada and California, that spread over many jurisdictions. And in the fall of 1970, there were a series of these devastating wildfires. Of course, we thought they were devastating back then, and now we realize what devastating can actually be, as the rate of wildfires and the intensity of them and the amount of damage done by them has significantly increased as we continue to face climate change. 13 of the largest fires were burning on federal, state, county, and city jurisdictions simultaneously, and they did not have good coordinations or plans. In the response, firefighters lost their lives. There was a lot of damage that might have been avoided if things had been coordinated. And you would think we would have learned a lot of lessons for that, but then we moved to 9/11 and we realized we still had communication problems during disasters. Fortunately, the government has done a lot of work to make sure that we are no longer having that same level of lack of communication. What should medical and public health personnel know about the incident command system? And the big question is why? Why do you think it's important? Well, increasingly, first responders are asking hospitals and healthcare departments to provide on-scene technical assistance. In a chemical or bioterrorism threat situation, health and medical professionals will be expected to play a major role in response. In emergency situations, public health has its own FEMA emergency support function, which is ESF8, authority in the incident command structure. Public health personnel and resources may be assigned to planning, logistics, operations, or administrative functions and become part of the unified command. And certain public health functions are key components of the incident command system. EMS may play a role in the operations section, while hospitals that are helping to provide patient beds may be a component of the logistics section. It just varies depending on the size and scope of the disaster, how big of a role healthcare personnel when the healthcare system will. We also know that the standards of Joint Commission require accreditation, and Joint Commission stepped up after 9/11, and they really did step up during COVID. And they tend to push hospitals to make sure they are prepared and to check that they are prepared. If you look at the incident command system, there is a standardized language they use, and it's important to learn the language in advance of a disaster. There is always an incident commander, and who the incident commander is changes over time. As an incident grows or gets bigger, who the commander is may change. That incident commander, depending on the size of event, always has a command staff that will always include a public information officer, which we think of as the press person, a safety officer whose job is to make safety calls and basically tell the incident commander if there is a scene that is unsafe or anything that would cause a safety concern. And then there is a liaison officer, and that's the person that goes out and deals with many other organizations, and sometimes those are state and local organizations, and sometimes those are volunteer organizations active in disaster. You will always then have 4 sections. One that's planning, and they do all the plans during a disaster, which seems obvious. The operations is usually the group where all the medical people report to at some level. Logistics is the people that move people and things. So they get you where they're going, and they get your supplies where they're going. And this is really oversimplified. And then finally, there's finance and administration, and they make sure you're not spending money that you don't have, because that's not legal, and that the bills are getting paid, and that people have money for travel and all of the supplies they need. They're also really good about making sure you're tracking, so there are records of anything spent. Civil defense has obviously changed a lot. This is an old civil defense museum, and I'm showing you these pictures because it somewhat reminds us where we've come from the civil defense era to now. And this was an old cache of supplies held in one of those, looks like a shack to me, but they were maintained at the time. And this is essentially what was considered the supply list. And you can see it's not much of a stuff. This was supposed to take care of, quite a few people. And this is what we have now. This is just one cache for the Strategic National Stockpile. And it's obviously all prepackaged and ready to load onto a very large. We also have federal medical shelters now that are pre-designed, and the federal medical shelters are meant to go out into a disaster and be set up to provide medical care. But let's talk about the role of nurses, and again, when I say nurses, I mean all of us as nurses. We have always been there during times of crisis, from the little things of answering phones to standing up medical shelters. But in the time of civil defense, in addition to routine emergency planning activities, nurses were considered to need to know many other things. So they were expected to know how many nurses are available in the community and be able to identify data for her own town, and at that time it was her. But now, fortunately, we are attracting many more men into the profession. Where will the information come from? Helen Tibbetts and Margaret Schaefer wrote that it didn't exist, and that the ANA was developing a national system of nurse supply statistics based on registration figures. Well, that never really happened. But what did happen is that many states have now started volunteer registries. And I bet for most of you, when you renewed your RN license, you were asked, would you be willing to volunteer for a disaster? And then, of course, we have medical reserve corps in many communities across the country. Some of the essential functions were basic levels of care during peacetime that would be considered seriously altered during situations where there are thousands needing urgent care. Didn't we see some of this happen during COVID? But one of the things we know is that while there was a lot of basic care that needed to be done, and those might have been done in some places in facilities that were stood up just to address COVID, Many of the people needed much more intense care, and that really hadn't been well planned in advance. There were 4 principles that needed to be emphasized when the demands exceed the resources. First of all, we need to be teaching everyone the essentials of survival care so that the load may be reduced at the source through self-aid and buddy aid. We need to do a really good job of triage, and we need people trained in triage. We need to know how to economically utilize supplies. And this is really important because you don't always have enough supplies to do the job the way you are always used to doing it. And I think that there are some states right now that are having to consider what you do when there are not enough people and supplies. And then you want effective planning and purposeful and realistic training. It sounds familiar to today, but this was from 1958. There are some assumptions that in an attack, the number of people will exceed the resources, including staff, equipment, and supplies. Of course, at that time in 1958, they were really concerned about nuclear war. Every nurse in any type of disaster should know how to determine priorities, evaluate patients' conditions, identify personnel needs, assess personnel and equipment availability, assign, supervise, and teach effectively, improvise, and identify resources and plan for solutions. This is also good advice if you want to open a private practice. So what are some of the things to think about with resources and solutions? First of all, how do you modify care? And it's important to remember that it's not the individual nurse or physician's role to decide when to modify care, but those decisions are generally made at a higher level. And there are a fair number of documents now in publication about exactly how we do this. We need to know how to modify procedures without violating basic principles, how to modify supplies and equipment. Again, we've seen this during COVID when people early on were talking about how you extend the use of an N95 mask, how you use a ventilator for more than one person. It's important to have knowledge and ability to reallocate functions. Sometimes you have to move people to areas they do not normally work in order to just manage the number of patients that one has. And then, of course, we want everybody to understand triage. So in the 1950s, nurses were not responsible for what they called sorting, which was triage, but nurses did play a role in evacuating patients already in the hospital to free facilities for incoming casualties, grouping patients within treatment units according to nursing needs and the severity of injury in order to make possible the most economic and effective use of personnel and supplies, recognizing change and complications in patients' conditions, and describing the most judicious use of scarce resources with the objective of doing the best for the most. Now, one of the problems with doing the best for the most, I will warn you, is that this is frequently problematic in major disasters for children, because to care for a child takes usually a little more time and a little more resources. And do we really want to say that we want to do the most good we can do for the most people and then put children who are very vulnerable at even greater risk? And of course, we do not. Some keys to nursing success, both then and now, are psychological preparation. You need to be prepared if you're dealing with mass casualties. You need to be prepared to make the hard decisions during triage. Nurses need to know what their roles are. A nurse a few days ago told me that notifying families of the death of a loved one during COVID has become their responsibility in some places. That's never really been a nursing responsibility. And people need to be trained and be psychologically prepared for that. You need to be prepared that sometimes care is going to need to be provided by people that are less qualified than what we would normally want. And then we need to know the consequences to the medical mission if an individual member of the team fails to be adequately prepared to respond. Remember, if people aren't adequately prepared, one of the things that can happen is rather than being of assistance, they become someone else for whom you must provide care. It really does help as a team if you make sure you're prepared before the disaster. You also have responsibilities as a citizen, so you need to know the warning signs. See something, say something. You need to know your community plan, how to protect yourself and your family from threats. You need to have your own home prepared and make sure you have your own first aid supplies. And you need to know exactly how a public address system is used and how you hear the messages. One of the big threats then and now, obviously, is things like an atomic bomb. From the 1940s to the 1950s, it was considered the most frightening scenarios. 80,000 deaths in Tokyo in 1945 might be nothing compared to what you might see today. The estimated casualties among civilians in 1953 planning was that there would be 60% would have flash burns, 50% would have medical injuries, 20% radiation sickness, and an enemy attack could produce 11 million casualties. And obviously, you would have massive damage. But there are many other disasters that happen today and that it's important for us to know about. For example, mass migrations and people held in detention facilities. And we see this with people crossing our border in mass, just for, off and on for years now. But right now, it's been a fairly significant surge. We know that holding people in detention isn't ideal, and we know that sometimes we meet them where they are. These pictures were taken in another country. And so the supplies and equipment that we had to work with were very limited. And one of the things that you always want to make sure you have plenty of and you're able to care for in a disaster are the people that have chronic diseases and still need care. Diabetes, COPD and asthma, common infections, HIV medications, people with heart disease or hypertension. You always want to have tetanus vaccines and other vaccines people might have. The last thing you want is a measles outbreak in a shelter facility or in one of the mass migration facilities. And then you want to be prepared to provide mental health care. Disasters are stressful, and people that have any underlying conditions, those may be exacerbated. We always try to take people that speak the language when we're dealing with populations that we don't understand. And we also try to make sure that we have at least the basic equipment. I use this picture because we had an x-ray machine when we did this mass migration, but we didn't have a viewing screen. So the best way to see the x-rays was to actually take them outside and hold them into the sun. The other thing you want to make sure you always have is plenty of things for hygiene and bedding. And hygiene kits need to include things like emesis basins, but also things for dentures and safety razors, insect repellents, sunblock, surgical mask and tissue, toilet paper, combs and earplugs, and shampoo and toothbrushes. And after the National Commission of Children in Disasters, we now include basins to bathe babies in so that people aren't having to bathe them in the sink. And then you always want to make sure there are bed packs that have plenty of blankets and sheets and pillows and washcloths and paper. This was a disaster drill involving children and a plane crash. And it's always concerning because when you do a drill like this, we did it specifically because there are lots of plane crash drills, but very seldom do they deal with the emotional needs of a children. And we wanted to discuss special considerations for children and identify the common things that providers might see or responders might see in relation to the stress that would be caused, especially if they lost a parent and they were separated. And then, of course, there's always the issues of reuniting families. The UN Convention on Civil Rights of the Child said that every human being below the age of 18 years, unless under law applicable to children, let me rephrase this. Children are under the age of 18 unless there's some applicable law that says it's something different. A child is a human being between the stages of birth and puberty. Legal definitions refer to children and youth as minors. As clinicians and teachers, we refer to children under the age of 18 and adolescents and this varies between 13 and 23. Some people set the 23 number at 21, and that varies depending on where you are. But children do have unique needs. In 2006, there were 73.7 million children under the age of 18. This is about 25% of the population. While the numbers change, the percentage hasn't. And children are often in disaster planning considered under these catch-all terms rather than as distinct populations. People may refer to them as vulnerable or special needs and various other things at risk. But it's always better if we can get people to think about them as children. Whether or not you're a child or an adult, one of the things we know is your major needs in a disaster really aren't health care as much as they are those bottom two rungs of Maslow's hierarchy of needs. You need fresh air, you need food, water, sleep, and clean restroom facilities. But you also need safety and security. Parents need employment, and you need to have contact with the family and with health, and you need your property to be safe. So just remember, food, clothing, shelter, air, water. These are the big things. It really isn't often as much medical. Everyone has emotional responses to a disaster. People who have experienced a disaster can frequently be quite traumatized. And consistent follow-up from the provider is important because the client's needs may change. You can't wait for the person to tell you there's a problem. You really need to talk to them, and you need to ask. People may not realize or be able to actually vocalize all their needs. And people may be vulnerable to others and be more susceptible to being taken advantage of after a disaster. And this is especially true for children. Some of the special needs that people have, when people refer to special needs populations, and this is language that changes over time. Again, some people say special needs, other people say at risk. Nobody is really happy with any of these words or any of the definitions that are used, but you will see this sometimes used in information about disasters. So these are populations whose members have additional needs before, during, and after an event. They may be in this category because they need assistance maintaining independence, they have communication issues, transportation issues, supervision issues, or they need medical care. Individuals in need of additional assistance are people who live in institutionalized settings, who are elderly, who are children, who are from diverse cultures, who have limited English proficiency, or who are non-English speaking, or who are transportation disadvantaged. And remember, we saw this in Hurricane Katrina and Rita. The people without transportation were not able to evacuate. Some special considerations from children is to always remember they are not little adults. And I know as PMPs, you know that. But all the people that you interact with that are not healthcare, they may not know it so much. Children are particularly vulnerable to aerosolized biological and chemical agents. And you saw this in your book chapter where it talked about the different physiology than adults. And I would highly recommend that you go back and review that, because it's not just that their lungs are different, but their skin's different. And this is important to understand. Children have significant developmental vulnerabilities not shared by adults. For example, they're told, don't talk to strangers. They may have questions about why mommy keeps crying and why can't we go home now? This is obviously far different than adults. Children's ongoing cognitive and social development processes also pose unique challenges. We need to reduce repeated exposure to media sources, and this is really hard because parents want to play it continually, friends and family want to play it continually, but it is not helpful for children. Children have ongoing needs that must be addressed by their parents and other caregivers, such as feeding, bathing, changing, and toileting assistance. Now, it isn't necessary that you bathe them every day, but it is necessary that you be able to bathe them when they need it. Children are particularly vulnerable to rapid spread of infectious diseases and exposure to toxic substances. They touch a lot of things, and they put a lot of things in their mouth that they have touched. So, children really do need more extensive care and supervision during a disaster. And it's really important to implement infection control measures like hand washing and routine cleaning and disinfecting, particularly in pandemic events. And I think we've all seen all the hand washing and all of the um, hand disinfectant that has gone around during this pandemic. But I bet you every one of you has been somewhere where you went in and you put your hand under the disinfectant thing and it was empty. So it's really important to pay attention to this. There are also special considerations for children during evacuations. Evacuation plans used to not incorporate children really well, but now they're doing a much better job of that. And there are many resources for reunification if that becomes an issue. Children's services and schools may be disrupted. And remember, if children are spending about 8 hours a day at school and parents are spending about 8 hours a day at work, the issue is there's a good chance that if a disaster strikes, the child may not be with the parent. When children are cared for in shelters and other disaster settings, child-specific supplies need to be provided. So you need child toothbrushes, and you need child-sized chairs, and you need child-appropriate clothing. But you also need child-appropriate medication doses and child-appropriate food. So if somebody brings in a bunch of MREs, well, that's not appropriate for a child. And if somebody gives us adult doses of aspirin, again, not appropriate for a child. The feeding plans and guidelines should stress the special needs of infants and young children, including possible allergies. I put this in there, and it's kind of old, but it really is a good little graphic representation of you, and you can take a screenshot or I can send your instructor the PowerPoint. But it really does talk about the phases a person goes through during a disaster. And you see this, the heroic, the tunnel vision, the honeymoon, the disillusionment, and the reconstruction and recovery. And it talks about the time and the phases, the emotions, the behaviors, and the most important resources. I think this is a keeper as a graphic. I've kept it around for years, and I hope that you will find it useful. Again, you can either screenshot it or I can send it to your instructor. All states have statutes that identify persons who are required to report child abuse. And individuals listed as mandatory reporters are listed below. And you will notice that healthcare workers are on the list of mandatory reporters. Approximately 48 states, the District of Columbia, American Samoa, Guam, the Northern Marianas Islands, Puerto Rico, and the U.S. Virgin Islands designate professions whose members are mandated to report maltreatment. That must also be the case during a disaster. Some of the varying needs of children that you need to consider is that you may run into children with developmental disabilities, children who have low English proficiency. English isn't their first language, or they're from a different culture with different cultural norms. You may have children who have prior traumatic experiences or mental health issues. You have a lot of extra considerations for children in foster care, children of migrant workers or people who are not documented, children who have been abused, neglected, or have medical conditions and allergies. These are all things that you want to make sure you know about if a child presents to you during a disaster. Children are not homogeneous, so just like adults who have unique needs, children have unique needs as well. And this is just a few of the examples. You also need to know that children have needs for supervision during a disaster. Children may be at increased risk of being abducted, abused, or neglected during a disaster because their parents or caregivers may experience unusual stress. Other people may prey on children during times of disaster due to disruption of the safe environments, and reports by children of any form of abuse or neglect should be taken seriously and pursued in an appropriate manner. Due to the stress of the disaster, children may choose that time to disclose that they have been mistreated. You also want to make sure there are educational activities for children. You want to try to normalize their life to the extent possible. And then, of course, there's always issues with transportation. Transportation systems and routes may be disruptive after a disaster. And it's important that when you're arranging services, you think about school routes, doctors' visits, and child care. So it's important for the child. All of these things help the child to have a sense of security and protection. You need structure and organization within the disruption and the chaos of a disaster. When possible and safe, interaction with other children, playtime, reading, and creating, helping them to have as much normalcy in their life as possible. There must always be safety and supervision, because I can't emphasize this enough. There is always an increased risk of being abducted, abused, or neglected during a disaster. It is a time that predators will prey on children. So, to repeat, you want normalcy to the extent possible, a normal schedule and environment. It's important to create this sense of normalcy for a child to reduce further effects of the disaster and to try and maintain this normal schedule. You want recreational activities, so play and interaction with other children is beneficial for the child. It distracts the child from their family's troubles, and it improves their quality of life. And you want family unity. Children frequently react better and are more appropriately cared for when they remain with their families. Families provide necessary supervision for children. And then you want to get long-term housing as soon as possible for families with children. There are reunification services you should know about, and these are growing all the time. American Red Cross Safe and Well is one. And then the National Emergency Child Locator is another. There are websites out there that you can visit, and these help you to connect children with families. Remember that it's always important to reach out to people in charge, and that a child should never, ever be turned over to anyone that is not a custodial parent under any circumstances. If there's not anybody, then law enforcement and social services will need to be involved. So what seems organized to us may be very frightening to a child, and especially if they are young. So the younger, the better. This looks organized. This does not look organized to a child. It's huge, it's open. There's crazy chaos in their views. But this, by the way, is an example of a staging facility. And when this is used during a disaster, it is very loud with a lot of people, and responders get frustrated, and sometimes there will be loud and heated conversations going on in there. There are designated work areas usually in a staging facility, but you can imagine what this would do to a child. The one thing I like to tell people is that plan one almost always fails. So you may end up in an area that isn't secure, is far from ideal, but is all that is available. This is one of my pictures from a mass migration where they told us we would have medical tents. This is not what we thought they meant. And we always say that children come first. And the reality is that safety and security come first. And only after you have a safe and secure environment are you going to be able to make it safe and secure for children. So you always want to make sure that you secure the scene first before you do anything else. And until it is safe, all we can do is wait. And like everything else, it can try our patience, but that is what we do. The other warning I will give you is about spontaneous, unaffiliated volunteers, and they can impact your efficiency and hamper your ability to respond. I do not like unaffiliated volunteers. I do not think it's helpful. This is a picture of a man accused of being a disaster relief imposter. So credentials are essential. In almost every disaster I was involved in, there was somebody that claimed to be a nurse who wasn't. And these people show up, and you really have to be careful because it does put children at a special risk if there are uncredentialed and unverified people in the area. Children may need to be referred to local or state child welfare agencies when they become separated from parents or guardians for extended periods of time. They may require guardianship. Domestic violence and abuse is likely to increase during disasters, and that may require child protective services. And then children may become permanently separated from parents and guardians. So remember, we need to coordinate this with American Red Cross or whoever is present that is dealing with the needs of the children. Again, I can't emphasize this enough. You never personally turn a child over to anyone unless you personally know that person to be the parent and the custodial parent at that. It is, I just can't tell you what the risk is to children during a disaster. And then children, to the extent possible, should participate in their educational activities. If you can, have classes on site or tutoring from community organizations. You can facilitate cooperation with local school districts to enroll people that might be refugees or evacuees or people in a mass migration or people in long-term shelters for any reason. Children also need to be enrolled in extracurricular activities. And one of the reasons you want to get children actively involved in things like after-school activities and day camps for them that seem normal is it also gives the parents the time they need to do all the work related to recovery from a disaster. Traumatic stress for children is significant and real, from the chaos of an evacuation to the loss of friends, families, and even pets, the loss and destruction of their homes, all of the things they know and love and make them feel safe and secure may be gone or removed. They've lost their community. They're frequently not around their friends, and it is a major disruption to the routine. Some of the psychological reactions that were listed in the Child Trauma Toolkit from the National Child Traumatic Stress Network, which, by the way, is still available and online and free to download, and I would recommend you have a copy of it. So some of the things you may see are regression in children. They may return to thumb sucking or bedwetting. They may have separation anxiety from parents or adults or older siblings. They may constantly ask for reassurance or seek self-soothing behaviors like rocking or pacing, hugging, and holding security objects. They will easily experience sensory overload, which can lead them to hypervigilance and feelings of being overwhelmed and out of control. And then if there are children that still have a nap time or an early bedtime, they may actually avoid sleeping. They may be waking up in the middle of the night, and they may have nightmares. They may have increased somatic complaints. And then, of course, you have to always make sure that you know what is a somatic complaint that's real and what is the result from the stress. They may have new fears. So they may have never been afraid of the dark or monsters under the bed or of dogs or cats before, but now suddenly they are. And they may, for the first time in their lives, have questions about death and dying. They may have lost someone, or they may have seen many people that did die. Each child has a very different reaction to the same event, just like the adults do. But based on resilience and previous experience and family dynamics, you can help them to a more rapid recovery. Some helpful things for responses and support. Children may want to vent to feel a sense of control over what's happening. So give simple and realistic answers to a child's questions and clarify any distortions or misperceptions that they may have. Be sensitive to the cues in the environment that may cause a reaction. So if it's getting really loud in a shelter, you may want to be sensitive and see if you can pull the children together into some quiet play, or even better yet, try to calm and quiet the situation. Be aware of other children's reactions to a traumatized child, and what information you share about that. Remember, children are more empathetic than adults, and they are more likely to feel what the other child feels than an adult is to feel what another adult feels. And though although not all children have religious beliefs, be attentive if the child expresses severe feelings of anger, guilt, shame, or punishment attributed to a higher power. And in almost all disasters, if this is happening, first of all, you should have mental health people present, but you probably also have pastors and ministers of some kind present, and they're frequently able to help with this. They're used to dealing with it more so than we are as nurses. So things that are particularly helpful to infants and toddlers and very young children. Very young children are particularly vulnerable to the immediate environment and their sensory experiences. Remember, especially for an infant really responds with the senses, and they don't communicate except through crying and smiling and as they get older, then laughing and giggling. But infants themselves, their reactions are to the sensory experiences, so what they see, what they hear, what they feel. If the mom or the caregiver is stressed, crying and anxious, the feelings can easily be shared by a young child. So it really is important for you as a caregiver to provide reassurance and support for parents, so that the parents can provide the reassurance and the care for the child. If the parent's distraught, it's helpful if you can find a supportive adult figure for that parent, and an adult that can provide kind of surrogate support for the child if it's needed temporarily. And again, you have to be really careful and make sure that you know who that person is. So a few last things here. There are long-term consequences of public health emergencies. Remember that pregnant women and children are individuals that suffer from chronic illnesses are disproportionately impacted by public health emergencies. And some friends of mine wrote an article on Zika and the Flint water crisis and public health emergencies and the long-term impacts that's having on pregnant women and children. We know that disaster nursing education is lacking for the most part. So kudos to your faculty for having you read this chapter in your textbook. We do have a disaster nursing education commons for the Society of Advancement in Disaster Nursing, and all of the information on there is free and available to everyone. And then kind of the reminder is that sometimes we create our own healthcare emergencies. Patients in the iron lungs from the 1950s. We managed to vaccinate our way out of this, and we could vaccinate our way out of COVID if we really wanted to. In conclusion, children are defined in special needs populations and at-risk populations. The potential impacts of a disaster makes them even more vulnerable than the general population. Greater intensity of effort and individualization is needed to help eliminate the effects of the disaster for children. And we must remember that functional needs may be present before, during, and after an incident in one or more areas, including, but not limited to, maintaining independence, communication, transportation, supervision, and medical care. Individuals in need of additional response assistance may include those people that have disabilities or who live in institutional settings, who are children or from diverse cultures, who have limited English proficiency, and who are transportation disadvantaged. So remember that when you're thinking of all this, even if you're saying, well, transportation isn't a child's issue. No, it's the parent's issue, and it impacts the child. But there are children that live in institutional settings, and there are children who have disabilities. Let me end with this quote. You must underwrite the honest mistakes of your subordinates if you wish to develop their initiative and experience. When you're in a disaster, you absolutely must underwrite the mistakes of the people that are working for you. It is, for many of them, a new experience. It is a stressful experience. And whatever the disaster is, they also are living through it. Thank you for your attention.